This is Dr. Abeje Brhanu, a plastic and reconstructive surgeon from St. Paul's Hospital, Millennium Medical College, Addis Ababa, Ethiopia. And I'd like to thank the organizers for giving me this opportunity to present in this prestigious seminar. I have no financial disclosure or conflict of interest with the presented materials in this presentation, and I would like to proceed with the rest of the presentation. So, the contents of my presentation include introduction, algorithm overview, patient evaluation, defect assessments, and reconstructive options, and finally we'll see a few points about the reapplication. So, as an introduction, the ideal reconstruction of lower limb defects should replace like with like, as it is in every other part of our body. We should try to replace like with like, and as much as possible we should try to minimize morbidity of the donor side, and at the end we should try to achieve the best possible aesthetic and functional outcome. And the goal of our soft tissue reconstruction of the lower limb should be attaining a stable healing, and to be able to give or to deliver to our patients to resume a very efficient daily activity or daily life. So, the importance of lower limb reconstruction can be jotted down as to restore function and aesthetics, or to restore function and form of the affected limb, and to prevent infection and complication, and to improve quality of life. So, taking this into consideration, our reconstruction or the soft tissue reconstruction of the lower limb should be very much considerate of these important goals and expectations of the final outcome. So the challenges of lower limb reconstruction, it emanates from the complex anatomy and biomechanics of the lower limb itself. So that is the first and significant challenge an operating surgeon will face when we are dealing with soft tissue reconstruction of the lower limb. So the complex anatomy and the complex biomechanics should be in our mind whenever we are planning to do soft tissue reconstruction of the lower limb. And the variety defect etiologies or defect origins. As we all know, the lower limb defect or lower limb lower limb soft tissue defect could arise from trauma, or it could arise from infection, or it could also arise from tumor excision. So in our institute, the other common cause for occurrence of lower limb soft tissue defect is a burn injury or a burn accident. So this all could be etiologies or cause for lower limb defect. And we should also put into consideration the presence of patient-specific factors, specifically the age of the patient, the presence of comorbidities, and ability or their financial status, and also their activity, or whether they are engaged in sport activities, or whether they are daily laborers, should also be put into consideration, and they are part of the challenge that we face as a surgeon when we are dealing with reconstruction of soft tissue reconstruction of the lower limb. So just to see the overview of the algorithm, so it's a form of a flow chart. I took this one from a paper published in the PRS Go. So the authors are from Korea, and they try to put the flow chart to illustrate the decision tree for the key steps in the algorithm. So lower limb defect, we should start by assessing the etiology, as we tried to see in the previous slide. So it should, then we can classify them as a simple defect or a complex defect. A simple defect will be a defect where there is no exposed bone, exposed tendon, exposed neurovascular structures, and exposed weight-bearing area. Or if it is not a weight-bearing area, we can say that it's a simple defect. And options for simple defect coverage could be a split thickness skin graft, or simple dermal substitute, or you can leave it to heal by itself by secondary intention, or a simple primary closure can suffice if it is a simple defect. But if it is a complex defect, by which if there is exposed bone, exposed tendon, exposed neurovascular structures, and exposure of the weight-bearing area or wound on the weight-bearing area, we consider it as a complex defect, and we can use of various options like a local flap and free flap, and there are current trends, and we'll discuss about them in detail in the subsequent. So the algorithm, we continue with the algorithm, and the main branch in the algorithm could include patient evaluation, which is the very important and the first thing to do. So when you are evaluating patients, you should try to assess their medical history, presence of comorbidity, and their functional goals, considering their daily activity, whether they are they are into sports, or they are sportsmen, or they are daily laborers, whatever function that they are planning to attain following the reconstruction. And the second thing to come is a defect assessment. So the defect should be assessed in terms of size, location, depth, and level of contamination should also be put into consideration when you are assessing the defect. So the other is we should look into the reconstructive options. That is the other branch of the algorithm. So the reconstructive options could include local flaps, regional flaps, free flap, or skin graft, and the list includes the skin graft, local flap, regional flap, and free flap. And the other thing that should be included in the algorithm, or that is included in the algorithm, is a post-operative management in a form of wound care, monitoring of our reconstruction, and also rehabilitation. So when you say patient evaluation, medical history of the patient should be assessed thoroughly, including presence of diabetes, presence of vascular disease, and history of smoking. And in addition to that, other comorbidities should also be assessed actively, because they may affect the healing of our flap, and they might compromise the success of our reconstruction. The other is the functional goals. So functional goals could be in a form of simple ambulation or engagement in the sport activity, and the aesthetic aspect of our reconstruction should also be put into consideration when you are dealing with a patient evaluation. In this particular point, you should also try to assess the overall, motivation of the patient, because that also will dictate our success at the end. Our patient should be motivated enough, and they should have a very realistic expectation of the overall reconstruction, and you should try to bring them to that particular point. They should have a realistic expectation of the outcomes of their reconstruction. So to come back again to the defect assessment, size and location, they matter very much, because the size will detect what type of reconstruction that can be done. So it's crucial for flap selection as well. And depth determines the need for bone and tendon coverage, as we discussed in the previous slide. And the level of contamination should also be put into consideration when we are selecting different kinds of flap. So they could also influence the timing of our reconstruction and the type of reconstruction. So if it is heavily contaminated, we might give a chance for wound care before considering reconstruction. So the other is presence. We should also put the importance of imaging and vascular study, because there is a need for us to look into the available options for the options for to be used as a recipient vessels when we are considering to do a free flap, or the overall vascularity of the affected limb should be assessed by using imagings like ultrasound, Doppler ultrasound, or angiography in a form of CT angiography, or other vascular studies will help us to assess the overall vascularity of the affected limb, and the presence of significant vascular injury, and presence or availability of recipient vessels. So to look into the individual or each of the reconstructive option, we start with the skin grafts. And as you see, skin graft is one of the options for lower limb reconstruction, and it's one of the straightforward options, and easy to do, and very much very much accessible for most of our patients, and it's the skills in doing skin graft is somehow easily achievable, and it doesn't have, I mean, a very steep learning curve, and it can be used to cover most of soft tissue defects of the lower limb. The advantage, it heals very well, it has a lower a risk of failure, and it has a very good learning curve for the for the I mean for a new or young surgeons, and also for residents as well to do it. The disadvantage, it cannot be applicable in areas where there are exposed bones, tendons, or exposed to critical structures. So the its use will be limited when there are I mean scenarios where there are exposed critical structures. So the other option is local flap or local and regional flaps, and the examples include fasciocutaneous flaps, muscle flaps, and regional flaps. So the advantage, it gives us the chance to replace like with like, as we put in our main goal to, I mean, main aim to replace a like with like. And the disadvantage, there might not be adequate soft tissue in the surrounding area of the affected region, or the affected trauma, I mean the affected zone, to do a local flap. But when they are available, they will give us a chance to replace like with like. There are a number of examples, like in this particular picture we see a reverse sural flap to cover the dorsum of the foot. So it's I mean the skin color and the skin texture looks somehow similar with that of the dorsum of the foot, but in this particular picture we can see that there is a need for a debulking, which can be done after 6 months, after 3 to 6 months, and it will give a good color match with the other dorsum of the foot. So still taking this particular paper, which is a base local flaps for lower extremity reconstruction, we can see various options in a form of local and regional flaps. So if you consider a tie, there are different options. If it is a small and medium defect, we can use a keystone flap or a propeller flap. If it is a large defect, free flap can be an option. But when you, our particular area of challenge will be the lower third or lower extremity on this, I mean the lower extremity, which is below the knee. So on this particular part, there are different options like soleus flap, gastrocnemius flap, and propeller flap in different options. Like still, there are a number of perforators, and those all perforators can be used in a form of a propeller flap. So you can see on this particular picture that there are various local and regional options that can be used to cover the lower extremity or that can be used for reconstruction of lower extremity. So in case of tie, we can use propeller flap in a form of a perforator flap, or a keystone flap still in a form of a perforator flap. And for the knee, you can use a propeller flap or a gastrocnemius flap. And for the middle leg, we can use a propeller flap or a soleus flap in a form of a vascularized or a pedicle flap. For the lower leg, we can use still we can use a free flap, and for both we can use a reverse sural flap, as we see it in the previous, as we seen it in the previous. So when you say free flap, it's the advantage, it gives us the option to choose for coverage of a defect in the lower third of the leg, with options that can arise from proximal part of the leg in a form of LT flap, or from the near to the I mean from the chest in a form of latissimus dorsi flap. So in this particular case, this guy was a 27 years old male patient who encountered a road traffic accident, and he ends up with exposed dorsum of the foot. So for this particular patient, what we did is we took a latissimus dorsi flap, and we use it as a free flap, and use anastomosis using posterior tibial artery as a recipient vessels in a form of end to side for the vein, end to side for the artery, and end to end for the vein. Then this is the final picture where part of the flap, free flap, was also covered with a skin graft, and at the end where the patient was able to work on it using uh, a support using a crunch. So when you consider rehabilitation, so you should put a due consideration for the wound care, for cause the area that we do a soft tissue reconstruction should get a proper wound care for a proper wound healing, and pain management should also be put into consideration as well, because unless we manage the patient, unless we try to make the patient out of pain, or unless we uh, make the patient free of pain, there will be significant negative effect on our soft tissue reconstruction, because there will be the patient will not have a proper physiology for which will help in a proper wound healing. So edema control should also be put into consideration. We should elevate the reconstructed limb, and we should use different maneuvers to reduce edema, because when there is edema, there will be occurrence of infection, and our reconstruction might be compromised or jeopardized. And early mobilization can be done, but it should be individualized. If you use a free flap for reconstruction, the mobility should be tailored based on based on our based on our specific reconstruction that we did. If it is a local flap, we can allow them to have earlier mobilization, but if it is a free flap, especially for the dorsum of the foot, the mobilization might be delayed up to 3 weeks or more than that. And range of motion exercise and muscle strength exercise also are part of the rehabilitation, since our major aim is to give the patient an efficient daily life. So, sorry, as not as a reference, as a summary, we can say that ideal reconstructions of the lower limb defect should replace like with like, with minimal morbidity to the donor side, and achieve the best possible aesthetic and functional outcome. And the goal of our reconstruction is to obtain stable healing and resume daily life in an efficient manner. Sorry, this is not a reference, it's a summary. Thank you for your attention, and if you have any question, that will be, I'm happy to reply, to respond to your questions. Thank you.